You know that there are stem cells in the blood of human beings.
Yes.
And when we do a blood transfusion
Yes,
from
it
one
is.
person to another,
Of
we're
course.
doing stem cell therapy.
Correct.
By transferring cross-type and matching.
Correct.
So how long have we been doing blood transfusion?
That's the thing. The root cause of it can be genetic. The root cause of it can be lifestyle choices. The root cause of it can be any other myriad of issues. But if we find the root cause of it and then we address it directly and it becomes a permanent cure, then everyone is happy.
Everybody, welcome to my stem cell journey, and I am here with the Honorable Dr. Nivit, and he has some great information, has been doing research for many years in stem cells, natural medicine. He is an expert in cardiovascular health. Dr. Nivit, can you explain to everyone a little bit about your background, what you're trained in, what you love to do, some of the things that you're doing now?
I've been trained in internal medicine and cardiology. I started practicing with stem cell about 3 years ago, and that was my first experience. And I've been utilizing and helping patients for the last 3 years by either utilizing stem cell directly for cardiology or non-cardiology cases as well. And I've been seeing positive results where cases are usually end stage or cases that are usually out of options suddenly improve and show positive benefits from utilizing stem cells.
So is this research only, or are people actually coming in and hearing about you and coming?
So it started off as research mainly. So I'm just, let's say, a small speck of the entire spectrum. But then it started growing from people bringing in more patients, usually patients who bring in more patients themselves. The keyword of most of the patients who end up coming to me are basically patients who have exhausted most of the resources available with conventional medicine and are either not improving or are worsening with the current state of their treatment and are looking for other options that are available.
So what are the different types of cardiovascular issues that you've been working with?
So the main cardiovascular issues that stem cells seems to be most promising is in what's called a non-ischemic dilated cardiomyopathy. So when patients come in with either acute or chronic heart failure, the diagnostic depends on the echocardiogram that shows us the ejection fraction of the heart. That means the capability of the heart's pumping out the blood itself. And usually these cases are very poor, very low. That means lower than 30%, shows that the heart muscles are dilated. About 50% of the patients have coronary artery diseases and usually can be helped by stenting, by ballooning, or even by bypass or even heart transplant. However, there's another group called non-ischemic causes of dilated cardiomyopathy, which means that it is non-related to the pump, the blood supply to the heart pump itself. So these cases can be due to genetics, can be due to alcoholism, can be due to myriads of causes. But the end goal is that in the studies, not all patients respond to medication. Even though we've just had a recent landmark trial about 3 years ago with newer medication that improves over the previous sets of medication that are now becoming a gold standard of treatment. But the ejection fraction improves by number, and a lot of the time symptoms don't improve. And so we come to sort of like a dead end because newest medication is prescribed. Ejection fraction shows mild improvement, but patients' symptoms are roughly about the same. So these patients fall under the category of requiring a heart transplant, and that is not easy. We do very few heart transplants a year worldwide because that requires a cadaveric heart in general, and we don't have that lying around every day. So these cases do not know where to go for the next set of treatment most of the time their cardiologists, their interventional cardiologists are telling them that you are at the end of the spectrum of all the treatments. So these are the cases that seek for what other choices are available. And it seems that from my experience, whether it's my cases or other doctors, other physicians' cases, there seems to be showing a really good response to stem cell treatment.
Can you explain the different types of stem cells that you're using and how those are injected?
So, well, embryonic stem cell, mesenchymal stem cells are the mainstay for now because they're easily available and producible for now. But in some neurological cases or some cancer cases, then we go more on the NK cell case more. But for now, for cardiology cases, we are going to be focusing mainly on the MSC cells. So.
And do you use a combination, or are those sourced from mostly umbilical or amniotic? Or?
So at the moment it's mostly umbilical, but I don't provide stem cells for my patients. So my patients are the ones who come to me with their own stem cell. Either it's from their own relatives or from wherever they can procure from. And we just check that it's up to standard, it's up to guideline, and as long as it's available for them, then I recommend them the dosage that is going to be utilized, how is it going to be implanted, and then when can we monitor the effects and the side effects of it mainly.
Are they also still on medications?
Yes. Well, the key issue here is that it is an adjunct therapy. So for me personally, I don't promise my patients that you can be off your current medication, but I'd rather utilize it to improve on the current treatment that they are on. So what I end up finding, well, because to us here in Thailand especially, stem cell therapy is still, let's say, in the wild west here, and a lot of people are utilizing it informally, uneducatedly, and are just utilizing it in any form of way advertised. And it's actually, we should be moving forward to a tailor-made medication route. I feel that that is the future that we should be heading to, because if you reverse back to the past, I think we were trying to produce one treatment that fits all. And now we are reverse engineering it back so that it should be individualized treatment for each particular patient. And there's absolutely no way that a large-scale study can support this theory and can support this practice in the long scale. So what ends up happening is that patients would be on the medication. So that's a large spectrum, that one medication fits all. And then we tailor-make the cell therapy for each individual cases.
Can people actually just go into a stem cell production laboratory and purchase them themselves, or is it they have to go to different doctors and find doctors to purchase them?
This is still, to me, I feel that the production here in Thailand is more readily available. The source of it, though, it depends on each lab, and each lab has their own certification, has their own qualification, and it depends on the patient as well. Meaning that if the patient requires MSC, that it's usually easier to procure, but if they require NK cells or so on, then it will be cultured from their own blood, and that takes longer. So it depends on disease, it depends on the implanting, what we are implanting and how we're implanting, and then the lab decides from there how is it procured.
How is it implanted anyway?
So for cardiology cases, most of the time it's being done via cath lab. So it's done in the via angiography, and it's being implanted directly. So the cell requirement is less because most of the cells get trapped in the lungs if we give it via IV or intraatrial. So we try to give it as implanted as direct as possible. So it's either done via femoral artery that goes directly to the coronary artery, or it's done via radial artery. So basically the same concept as stenting, but just with cell therapy.
How soon do the patients usually see results or feel results?
So if medication alone, we start monitoring side effects in the first week, and we monitor the improvement in 1 month and 3 months. But usually with cell therapy, the uptake is about a month that we start seeing the improvement. And usually by 3 months or 6 months, we should get to see if the patient is a responder. That means that you will see a difference in ejection fraction.
What about lifestyle changes? Is that another factor?
So, well, the key word here is that a lot of the patients want a quick fix and an easy fix. And whether it's medication, whether it's stem cell therapy, whether it's lifestyle changes, I think it has to all be done concomitantly. Even if it's a guideline, whether it's a diabetic guideline, heart failure guideline, the first step that is recommended for all patients will always be lifestyle modification. So it's not just about the diet, it's not just about the supplement, it's not just about the exercise. You start diving more into detail about the job that you're doing, how hazardous it is to the disease that you have. We dive in more into the sleeping pattern. We dive in more into the type of exercises that you should be doing. So I don't feel that it's only about an alternative doctor or a non-conventional doctor that focuses on this. I think that actually all physicians should focus on this and give time to the patient, give time to inquiring the information, and finally dole out the advices that should be done, the advices that matches the patient. Because again, you can just tell everyone to go for a run, but that doesn't answer all the questions, and that might pose more problem in the long term as well. So if a good physician is there that's ready to listen, and I think can share that knowledge that he's been studying up on, and share the type of lifestyle choices the patient make, and I think at the end game, whether the patient is improving from the medication, improving from the stem cell therapy, or improving from the lifestyle choices, improving is improving. For us, it's a good thing already to begin with.
And a good thing for them, too.
Yes.
Is there anything someone could do in advance, like detoxification, cleansing, cleaning up their diet, anything they can do that would enhance the benefits of the therapy?
Yes. Normally, basically, low sugar, low carb diet is the best way. I don't say zero carb because Atkins diet is already been disproven. Proven to be harmful. But the lower the sugar intake, the better. I never recommend my patients to go to zero sugar, but the lower the better. Lower the carb, the better. Higher protein, higher fat. Again, fat means good quality fat as well is the best way to go. But again, it's a case-by-case recommendation. So if a hard case, a lot of the time usually accompanies with chronic kidney disease as well, even though they might not run a dialysis yet, but usually hard cases accompany with lowered GFR, lowered glomerular filtration rate to begin with, and to do heavy protein loading on these patients can have its own downside as well. So each particular patient should have a specific set of diet regimen being discussed, their timing, when do they go to work, when do they come back, are they no longer working, are they retired, are their meals on time, how are they having their meals, which nationality of food is their main source of food as well. So we go from there and we discuss from there. So like Dr. D must meet a lot of patients as well, and from multifaceted from the planet. So it's easy for me to tell my local patients how to eat, but if they come from different countries, then I start having to research more what is their basic diet and then advise them accordingly.
So you've seen a lot of positive results?
Yes. I've seen a lot of the cases in my hand, a lot of the cases that are not in my hand, I've seen a lot of positive result. Either it's prolonging dialysis, whether it's reducing dialysis time, whether it is reducing heart symptoms, whether it's increasing functional capacity, meaning patients can improve their daily activity. A lot of the times it can also boil down to improving sexual function, improving dietary function. So we don't skimp on the details, and we do see a lot of improvements.
Do they need to come back in 6 months for another treatment or a year? Or?
So not necessarily always, but yes, the cells improvement do have a lifespan depending on what organ we are attacking to. Most of the time is 6 months to 1 year that we recommend our patients to come reevaluate. If it is a permanent solution, then we don't recommend to do any further treatment. But if it is a temporary solution, that might require us to repeat the treatment again.
Have you ever had a case to where you've gotten so much improvement that they've been able to get off of all their medications?
I wouldn't say get off of all their medications, but been able to reduce their general medication. I mean, I've seen cases that have had stem cell implantation into the spinal cord that can start walking again from quadriplegia, means all 4 limbs are non-functional, back to walking again. Maybe some patients want more. So I've had patients who have neurodegenerative disease like ALS or Kennedy's disease, that they are at the end of the spectrum of their conventional treatment, and utilizing cell therapy in these patients show improvement where they've never seen before. So I can give you an example of a case that is in a nursing home care that underwent study and did an implantation via IV and via spinal cord, and found to only about 1 month after the patient could walk, and now is let's say self-reliant, and now is outside of a nursing home care taking care of himself. Maybe he's not back to his normal self, but at least he doesn't require another person monitoring him 24 hours. Now, the downside is that he has vocal cord paralysis and he cannot eat on his own. He still requires a tube feeding, and he's been unsuccessful for forward treatment for his vocal cord. So he didn't get back 100%, but to me, that was a win. To the patient, of course, it was a win at first. Now he wants more and he can't get. So it might seem frustrating that it's not a be-all, end-all, but it's better than what it was before.
How fast are the advancements happening in this field? I mean, where do you see this 5 years?
That depends on the regulations. Because again, there are people who are utilizing like it's the Wild West and overclaiming, overutilizing stem cell, either profiteering off of it as well. So that is the part that hinges the progression in this particular field. Because of course there is cost to producing, there is cost to all these type of treatment, and it has to be addressed. But overclaiming to me seems to be the biggest hindrance right now for stem cell therapy to move forward. I mean, if we don't count the religion aspect of it, or if it's just science-based only, I feel that the moral ambiguity of it goes out of the question in the long term of things, because the people who are debating for it and against it have their own personal preference or personal agenda. But I think collectively we can only benefit from further studies on it. So I feel that whatever hinges that are being put on that delays the progression of science is either political, religion, or financially motivated.
What's the religious aspect of it that people are...
Well, over here, it's basically the people who travel here to utilize stem cells don't have any religious aspect for it. But I think in the States, there is still I don't think that they can differentiate political agenda and religious agenda over there. So I think it's two peas in the same pod for now. But for scientists in general, I feel that no matter what, we need to move forward, and we should not have barriers on that for now. For here, it might not seem as such a hindrance, but because studies can be done in such a bigger population, I mean, a country like this has 70 million people. a small tiny fraction of it can afford stem cell therapy. So if studies are done in such a small population, we won't see much progression. Number one, the cost has to go down in producing it. That means that more people have to utilize it. The economy of scale has to come in to play with it. It has to be produced and studied the same way that pharmaceutical companies are doing it, but because they don't have incentives in this particular format, so it's being done by individual doctors, it's being done by individual labs to do these studies, and then cost becomes a big burden on them as well.
What are you excited about in the next? Do you have something on your plate that you're like really looking to do, or
well,
something you're excited about in the next couple of years?
Spinal treatment with cell therapy coupled with nanotechnology is the way to go for paraplegic, for any immobility, whether it's accident or neurodegenerative disease. I feel that is the easiest gateway to get cell therapy approved worldwide and the progression to come in, because I feel that for patients who suffer while still fully conscious, while still fully aware and not being able to move, I think at that point everyone would give everything to come back, and I think everyone surrounding those cases would do the same for that particular patient, and we just need to put economy of scale on that and just bring that into light, that yes, there is going forward. Now with nanotechnology, chip placement in the spine itself, directly into the spine to help computational with AI technology into it, we've seen a lot more improvement. For chronic cases like heart disease, that patient improving his lifestyle each day can be impactful for one case, but for one case that is bedridden for 10 years and is walking again, I think the impact factor is much stronger on the medical community.
You can get somebody walking again. That's like on a miracle level right there. Why is it that you think that stem cells are not approved?
There is two ends of the spectrum, people who benefit from it and people who don't benefit from it, right? So these two sides are it's two sides of the same coin, to be honest, is that I feel that people who don't benefit from it are trying to suppress the production, trying to suppress the study, and the people who benefit from it is also trying to suppress in the long term, as in financial benefit, because if it's readily available, then of course profiteering becomes less. Mm-hmm. So it's two sides of the spectrum. People who are utilizing it are benefiting from high costs and high pricing, and the people who don't benefit from it are suppressing it so that they can produce and sell their products more. So again, it's from the same coin. So, but if you look at it from a humanities perspective, moving forward, we haven't reached this advancement in medical breakthrough in a long time, and I feel that this is basically the next big concept from antibiotics to now. So I feel that we've come to a point of antibiotics that have prolonged our life well enough to come to a point where we have to prolong our life further by utilizing stem cell.
There's a real lack of education in the United States in the general public. And there's also a state of fear when you talk to people and you ask people about stem cells. And, what would you say about if someone was to ask you, are stem cells safe? I mean, what about the diseases? Or what if the mother was eating bad? Or what about any type of genetic disturbances? I mean, how do you know that you're going to be safe and feel safe whenever you get treatment?
It's the same concept as receiving blood, if you ask me honestly, because it's a human compound. If we haven't been able to manufacture lab-produced blood cells and we are okay and accepting of it, what's the difference between accepting that and accepting stem cell? Because the rigorous procedures that we go through with blood tests is not nearly half as rigorous as what we go through with how we vet our cells. So
that's an important time for my question. Do you know that there are stem cells in the blood of human beings?
Yes.
And when we do a blood transfusion,
Yes,
from
it
one
is.
person to another,
Of
we're
course.
doing stem cell therapy.
Correct.
By transferring cross-type and matching.
Correct.
So how long have we been doing blood transfusion?
That's the thing. So I feel that that misperception is being manipulated or propagandized by certain faction, a certain political belief, medical beliefs, and so on. But again, that's also because we have come so far with blood transfusion that we now accept it as a norm and that we trust in the system that regulates it. So I feel that eventually we would have enough labs producing, we would have enough hospitals producing these cells, that we would entrust the people who do it, who produce it, to have a rigorous testing procedure for its safety and efficacy as well. Of course, if you reverse back to 200 years ago when blood transfusion was relatively new or something unheard of, then everyone gets scared. And there were side effects because we didn't know why they were the side effects as well. Now we've completely understood it and we are no longer in the dark about it. So I feel that we need to understand it and we need to move past that fear and start learning, start giving educational, let's say, lectures or even studies done about it, about if we don't want to progress so fast about the treatment part, at least the lab qualification control should be done, the lab qualifications standardized around the world, that at least, okay, now the labs that are producing the cells have a gold standard of qualifications and investigations that go through. Then everyone can be more relaxed, everyone can be more accepting about these type of treatments as well.
What was that first moment? Like, how were you introduced to stem cells? Like, how did you even get into it?
Well, after seeing patients benefit from it, then I had to start doing my own research. So I started looking up for more papers that have been done, started researching about what cases benefit from it and how can I interject my particular specialty into this particular field. So it started off with seeing a drastic improvement in patients that I'm not particularly involved in, maybe adjunctively helping the patients in their cardiovascular problems, but seeing that the other problems are improving via stem cell treatment with other doctors. And then, then I started reading upon more how can it help in cardiology as well. That sparked my interest, and then it just went down a really dark and let's say deep rabbit hole. And then I separate out the financial aspect, separate out the the qualms about patients who have utilize cells and have negative impact. I have to try to bring that back to show what's the main reason where there's a negative impact, then start seeing the positive impact, and then if there's more positive than negative, what's the biggest downside negativity of it is basically what? Fever, rejection, basically waste of time, right? So in cases that have already reached their end game in conventional medicine and do not uptake the cells, means that there are no other options, and that's it, that's the end of the road. But if cases that end up turning to be good responder to the cell therapy, why not? So that just leads down a really long and winding road, and then we're here.
So you basically been pioneering this with your own research. There wasn't like a doctor that you went and trained under?
Well, I've been collecting researches from all around the world to see, but the group of patients that I get to be involved in, they have their primary physician. I'm just there to either implant or either to implement other treatments that are required. But they have their own studies, and I'm more of just a good researcher and just a good follower for now. But in the near future, hopefully I can get to be a good pioneer in this field as well.
What would cause a rejection, and how often does that happen?
It depends on so we've had cases that reject the cell. Either it's meaning the no uptake, meaning patients show no changes in biomarkers at all. So it's either cell control quality, which to be honest, I've never seen poor cell control quality, but it can also be from patient factor itself, that maybe it's the high hypersensitivity to the cell itself. If a case develops an allergic reaction to the cells, that means that that case would end up not being able to utilize that particular batch of cells at all. But it doesn't necessarily always means that we've hit the end of the road. It just means that that batch might not be the best batch for the patient if there's an allergic reaction. So we switch donor, we switch cell production labs, and then, but then again, it has to be discussed with our patient as well, because if they're willing to risk the same side effect of it again.
What would be considered a bad allergic reaction or something that would?
So the maximum that we've had was near anaphylactic. It hasn't been to a point of anaphylactic, but patients started wheezing, patients started having angioedema. So we had to give adrenaline IM and we had to give dexamethasone. But most of the cases are given dexamethasone before. Most of the cases are given CPM first generation antihistamines before. But that case had to end up being hospitalized for a day or two after the implantation. And the sad news was that if there is an allergic reaction, most probably that means that the patient didn't uptake the cells as well.
Well, that's still not usually a life-threatening.
If the patient is done under controlled setting, done under supervised care, then that is barely anything to worry about.
Really easy to deal
Yes,
with that. That
correct.
happens every day with foods
Correct.
and everything else.
Correct.
That happens so much in the States, especially with children now. 8 out of 10 kids under the age of 12 right now have some form of allergies. I mean, it's just shocking to see how many inhalers and how many EpiPens and everything. I mean,
I completely agree. And I think, you see, because pioneering in this particular field opens up more about genetic studies, open up more about cell study itself. And I feel that in the long term of things, we are not going to go to a hospital and then go to a pharmacy and pick up a medication, but we'll be culturing our own medication in a lab that suits your specific need, and then it won't have any side effect because it has been designed specifically for you. Maybe we're still a little bit far off from now, but I mean, eventually we will have to reach that point.
I would love to see that. I would love to see that day where we can not have to use pharmaceuticals to treat the symptoms, but actually address the root cause and actually
definitely. And the thing is, the root cause of it can be genetic. The root cause of it can be lifestyle choices. The root cause of it can be any other myriad of issues. But if we find the root cause of it and then we address it directly, and it becomes a permanent cure, then everyone is happy. I'm not just saying, of course, pharmaceutical companies who are responsible for it will be happy, patients will be happy, doctors administering it will be happy. No doctors want repeat patients. Everyone always have this misconception that the less patients we have, the sadder we are. Actually, no, the less follow-up that I have with my patients, the better it is. That means that I always tell my patients that the next time I see you, I want to see you when you're here for a checkup, when you're done with your disease, when you're done with your medication. But sadly, a lot of the chronic cases, and even as simple as diabetes, we don't have a permanent solution for our patients. We just have something that prevents it from aggravating other issues. We have medication that reduces cardiovascular outcome for the patients, but we don't have a one pill that fixes it. And hopefully with stem cell therapy in the long term, we should be developing one soon.
Have you done stem cells? Any type of stem cell treatment yourself?
Personally, mine is more for aesthetic purposes, and it helps. I've done personally with my hair. And so I've had an issue with alopecia universalis before, which is hair loss from head to toe. and I got my hair back.
That's
But
amazing. Your hair looks great. By the way.
but
You look like you're 14
but
or
again,
something.
because I did not just do cell therapy alone. I did conventional medication. I did lifestyle changes. I've did supplementation, and I've done stem cell therapy. So it's actually all. It's not just one. But because the treatment doesn't guarantee a cure in all aspect of things, so I just decided that before I can practice in other people, why not just practice it on myself? And yeah.
Did they inject?
Yeah,
inject
directly into my
the
scalp.
Scalp, right?
Correct.
And did you just do that one time? That's a very interesting subject, by the way, because we get so many questions about natural hair replacement in the U.S.
Okay.
So if you don't mind just talking a little bit.
Okay,
about that,
so well, mine is not a male pattern baldness. So a lot of the patients that ask me are usually male pattern baldness related. So mine was an autoimmune disease related. So with that, I tried to regulate my autoimmune via lifestyle choices. So I used to sleep around 3 hours a day. Because I read intensively, I was doing a lot of studies and so on. So I changed my sleeping pattern. So I started sleeping more. I slept between 6 to 8 hours a day. I changed my diet behavior to be cleaner, leaner, reducing in sugar, high in protein, started exercising daily, and reducing my working hours. I did have to take steroids at that time. I took steroids at a relatively high dose, and I was looking into oral chemotherapy to treat it as well, but I was withholding it for my first hair cycle. After my first hair cycle didn't come back, and then 3 months after that, for my second hair cycle, that was when I started doing cell therapy on my head as well. But I wouldn't say that I would attribute my improvement to just the cell therapy alone, and I would not ever condone any of my patients who are on their conventional therapy to stop or withhold their conventional therapy before they see improvement themselves first. So then I started tapering off when I got my hair back, and then
is there anything that someone could do after stem cell treatment that would completely nullify the stem cells? Like they just go out and do a bunch of drugs and drink and eat a bunch of bad foods? I mean, what?
Of course. I mean, if the disease itself is a chronic disease that has an impact factor from your social standpoint or your lifestyle choices, and you continuously ongoing, the improvement won't last. So if you're talking about like an autoimmune disease like SLE or like lupus in general, if you keep exposing yourself to the sun while you have already been recommended to not expose yourself to the sun, and of course it's going to come back. So it's disease specific more, but yes, there's no point to heal a burn by repeating the burn, right? So every doctors in general always have a good analogy to try to explain, and the easiest way I explain to most of my patients would be, our body is like our car and our surrounding is like the road. So if you fix the car and you still drive on a crappy road, your car will still break down, right? So you have to fix the road as well as you have to fix the car. So if you've spent your time, spent your hard-earned money with all these expensive treatments already, and then you're still driving the mud, it's going to result in the same result. You can't take a supercar on a muddy road.
I know you kind of assist in the whole thing, you're not directly related with it, but can you share a cost that patients would, just a roundabout number that they would get from their stem cell facility before they come to you? I mean, is there an average cost range?
The thing is that it ranges so different in each individual cases. The amount of cells as well is too far apart. And to be honest, I personally try to avoid getting involved in the financial aspect of things. So I give the best recommendation for the treatment that the patient should receive. And if the financial plays a role in it, then we have a discussion about the pros and cons, about reducing the cost, what can it be, and so on. But at the final integrated part of it, I try to shy away as much as possible. I feel that physicians should consider the financial burden on the patient and give them all the available options, but should not get directly involved.
I've heard that anywhere between 60 million and 600 million cells can be used. Is there, I know you're saying every patient is different. Is there, but can you expand on like how someone chooses how many
So
cells?
it depends on the disease severity and the study that are there to support it. So in the diseases that have been confirmed that there are studies that show supporting, then we go from there. We calculate by weight and then we start from there as well. So like for rejuvenation cases, usually start from 0.5 million cells per kilo ideal body weight, and then go from there. So if the ideal body weight is supposed to be 60 kilograms, then the cell utilization for that rejuvenation cases can be 30 million cells. But in chronic inflammation cases are usually 1 million per kilo for ideal body weight. So it usually, that's the start and runoff point from there. And that's how usually most studies are done, and we can cite them on that. And then, but again, we adjust if there's high inflammation counts. We might have to increase the cell therapy. If the ejection fraction is very low, we increase the cell therapy, but not always necessarily done implanted directly. The rest can be done via IV or so on as well. But we try to give as directly as possible. Why waste the cells in other areas and other organs if it's not required?
Because they're just going to go wherever they
Correct.
need to go. So that's you're not focusing on that one
Correct.
organ. Okay, so thanks a lot. I really appreciate
No problem
your
at
time
all.
today.
No
and,
problem at all.
Thank you for coming
Thank you,
by.
Dr. D.